orthopedic surgeon, been involved with sports medicine for the past 30 years here. And one of the things that we've developed over the last 4 years, 5 years. Marie. Can you hear me back there, Marie?
Yes.
Okay.
Or I can hear you.
Time to sit down.
Can you hear me?
Unfortunately, yes.
He's used to that.
So anyway, tonight we're going to have a concussion discussion, go over some different aspects of concussion evaluation, care, and what our program is all about. Jeremy Vanderhurst, right here, is our athletic trainer, and he's our concussion coordinator. Morgan Humble is one of our physical therapists, and Joe Dianovich is an occupational therapist. And the four of us will be talking tonight, hopefully briefly, so we stay awake, alert. Marie?
I'm alert.
Okay. You guys can hear me okay back there?
Yes.
That's great.
Okay, very good.
Sounds good.
All right. So just a couple questions. Is anybody in the room involved in coaching youth sports? Do we have any coaches in here? Does anybody have children that are playing sports? Got a few of those. Do you have anybody that's had a concussion before? A lot of people. Okay. Very good. So we'll get underway. So, Chris. There we go. So we have put together a team of providers that are involved in our concussion program. It's pretty lengthy, involving both primary care, psychiatry, speech therapy, occupational therapy, physical therapy. But we have athletic trainers at the different schools that are kind of the lead people to identify who's having concussion issues. And then we have a trauma program coordinator. We started this initially looking at just the youth athletic and high school sports concussions, but we rapidly found out that the emergency room had a big issue as well, trying to get the people that come into the ER that have concussions and getting follow-up care and getting the proper treatment for them. Do I need to stand closer, Chris? Chris left because he knew this would happen. So anyway, we'll talk about how to recognize concussion, what recovery is about, and return to sport. All right. There's a group that gets together about every 4 years, international group for the, we have an international conference on concussion in sport. 2 years ago it was held in Berlin, and they look at all the new data that's come out, different studies, to come up with a consensus statement. And at the heart of it is defining what a concussion is, and it's evolved over the years. But the definition is it's a traumatic brain injury induced by biomechanical forces. So there's some impulse that either a hit or not hit, and it can be either a direct hit to the head, but it doesn't have to be. It can be a jarring. And what this slide over on the right shows is just the progression. So it took me a while to realize it's sort of head, but when we started the head going forward, the brain is bathed in the cerebrospinal fluid. It's basically held in water. So as the head goes forward, the brain lags behind. When the head starts going back the other way, the brain is still moving forward. So I had these acceleration, deceleration injuries that occur. So it typically is a short-lived injury, but it can evolve over time, and it can be long-lived as well. It can last for anywhere from weeks to months to get over the injuries. It may result in neuropathological changes, so it can result in loss of consciousness. It can result in visual disturbances. Jeremy's going to get into a lot of the different symptoms, but one of the key findings is that in the past, it's been something that has not been able to be diagnosed by the conventional studies, MRI, CAT scan, X-rays. It's been more of a clinical diagnosis. And we'll talk a little bit further that there are other studies that are now coming out from functional MRI scan to actually blood tests that can aid in the diagnosis of whether a concussion has occurred. And one of the key pointers is that it may or may not involve the loss of consciousness. So being knocked out isn't part of it. Somebody can be perfectly awake and alert, but it's an altered state. So they may describe fogginess and a variety of clinical symptoms. There we go, epidemiology. So epidemiology is how does it present in the public? What are the different factors of how many people get injured, et cetera? So this slide is already outdated, and it was from 1 year ago. The estimates at that point that there were 3.8 million sports-related, and when you see the MTBI, TBI stands for traumatic brain injury, and M stands for minor, and that puts it into the concussion range. When you get into a major, then we're talking about other head trauma damage that is more long-lasting and permanent functional disturbances. They saw a 62% increase in the first decade of 2001 through 2009. And part of this is just based on increased participation in sports, but also increased reporting. It's become very aware in the public consciousness of first through the football players and the chronic issues that have happened from that. The highest incidence is in football, and then women's soccer, men's soccer, women's basketball. If you have the same sport that men and women participate with similar rules, women have a higher incidence of concussion versus men, male versus female. More often in competition versus practice, and that would reflect the intensity of the participation. In practice, maybe holding back a bit. In game time, going full bore. And then the other thing that was interesting, they did a study looking at how often people report having a concussion. In high school football, only less than half of the kids would report that they had a concussion. And there are a number of reasons for it, but the other thing is that most often they tell the athletic trainer. And that's the rapport that the trainer establishes, and also the fact that the trainer is watching the game, watching what's going on, and they're really focused on not calling the next play, but what's happening with their athletes. Out of the ones that didn't report, most of them felt it wasn't serious enough to report. And there's also a group that didn't want to have to sit out. They knew the consequences. If they did report, they'd be told to sit, and they didn't want to do that. There's no such thing as a minor concussion. Everything needs to be taken seriously because there can be significant repercussions that happen. So the signs and symptoms, Jeremy will go over this a bit more, but the things that if you experience a head injury, or if you have somebody that, a child that does it, there are a lot of different ways that it will present. The symptoms of having a headache, feeling like they're in a fog, feeling dizzy, blurry, can happen. There may be signs that go along with the loss of consciousness, but also amnesia, loss of memory. We talk about retrograde, what happened before the injury, or antegrade, what happens after. And there can be a period of time where they just don't recognize or realize what happened. Usually that memory will come back, but sometimes there can be a permanent loss. Neurological deficit is typically not the norm, but it's usually short-lived when it does happen. And some of the visual disturbances and the like, those things can be prolonged, and that's where PT and OT come into play. Slowed reaction time as well. That plays into how we diagnose things as well, and how we monitor recovery with different testing that looks at memory as well as reaction time and how quickly people respond. What we try to do is get normative values established before an injury happens. So we screen people before. There's one test called an impact test that we use. And that way, if there is an injury, we can monitor how fast they get back to their normal baseline. There can be balance issues, behavioral changes. Sometimes this is hard to tell in a teenager because they're all irritable and they complain that they're tired. and they're anxious about things. But it's one of the things that as a parent you can pick up that my kid just isn't behaving normally, or a family member. There's just something that doesn't seem right. And it's one of the questions we ask when we're looking at trying to return somebody to play or where they are in the progression. How are they behaving? Is this your kid? Is this the person that you typically see? When we get into the pathophysiology of what's happening at the cellular level, there's been a lot of research that's been very helpful in this. And when we talk about the different things that happen, there are chemicals that control the way the nerves work. So the sodium, potassium, calcium are all involved. The feeling is that the big part of this is a stretching of the axon. The axon is what connects the nerve to the muscles, to the sensory, and interconnection between nerves. So there can be disruption of the cell membrane. We can get stretching of the axon, but we start to get some different fluxes or movement of ions and that are happening in a way that they typically wouldn't. So when we look over on the right side, that's the picture for the typical sodium migration, sodium channel that happens. And in inactivated state, it will open and will close as needed to properly regulate the transmission across a membrane. But they talk about refer to it as a flapper valve, and if we have a stretching and these valves get injured, we can get too much sodium, potassium, different ions that are crossing the membrane, and get dysfunction of the nerve. Go back one over here. Oh, I hit the bad one. Okay. Chris warned me about that one. But this slide over here is looking at also what happens at time zero with a concussion. There can be, it can affect the way the blood flow comes to the brain. So we have a decrease in blood flow. At the same time, there's an increased demand for glucose, glycogen, into the system. So now you have the blood isn't going as fast, the glucose demand is high, and you have a mismatch. And it affects the cellular capabilities. Our metabolic rate is down, and it takes time for this to normalize. A lot of times the feeling is that the symptoms of a concussion may be resolving in here, what we see the patient, the athlete complaining about, but there are changes that are still going on beyond that. And that's the concern, that there's a silent part of the concussion that we aren't seeing what's happening, and the ramifications are big. I'll stay with that one anyhow. And we'll talk a little bit more about this one. This is looking at the cell, the axons, the myelin sheath, and with the stretching, you get disruption, and there are different chemical markers that get excreted into the blood. So in the majority of cases, symptoms will resolve over the course of 1 to 2 weeks, and that's what we expect out of a concussion. But there's certain things that contribute to prolonged symptoms, and it can be from a history of prior concussions, the severity of the concussion, how many symptoms they experience, the age. Younger patients may take longer to recover, and all these things can lead into things that affect the recovery. Unrecognized or undertreated concussions have ramifications as well, where the symptoms go on for a longer period of time. There may be more severity of the symptoms. There may be impairment that affects the ability to get back into the schoolroom, the classroom, or get back to your normal work activity. And it just stresses the importance of having in the school population, having the athletic trainer, there to recognize it early and get the process and recovery underway. But more importantly, there's also a condition called second impact syndrome. We'll talk about that a little bit more, but it's when somebody's had a concussion, they haven't fully recovered, and then they have another injury on top of it. With repetitive injury, again, increased severity can lead to memory disturbances, and then chronic traumatic encephalopathy is what they talk about in the football players, and all the press that's been there. There is was it Denzel Washington who did the movie Concussion?
Will Smith.
Same. Okay, Will Smith. And, yeah, if you haven't seen the movie, it's really a pretty interesting movie, and how they do a good job on the presentation of what goes on with concussion. Okay. Complications from concussion, prolonged recovery, persistent symptoms, and susceptibility to more further concussions happening with less trauma involved, less impact can lead to repetitive concussions. So the post-concussion syndrome is where concussion symptoms can last for longer than 3 months, and it can be a very debilitating problem. Loss of concentration, loss of ability to get back into the classroom. Convulsive motor phenomena, those are when you see a seizure that happens immediately after concussion. It typically is not something that becomes a long-term issue. It's managed acutely, so you deal with the convulsions as it happens, but it typically is a one-off thing. It happens one time, it doesn't happen again. Whereas we get into the problem of post-traumatic seizures, and if somebody has a delayed seizure, a second seizure, that is something that they're at risk for repetitive problems, and medication or long-term therapy is frequently required. Depression, impairment of your cognitive function, the chronic traumatic encephalopathy, and second impact syndrome are all other ramifications of concussion. And second impact syndrome is, again, as I mentioned, it's when you have a second injury when you haven't fully recovered from the first. It is more prevalent in young people, and in one study they saw that there's a very high correlation to sudden death after in this setting. So it is something that we take obviously seriously. You can find videos online about kids that have gone back into play and either didn't report they had a concussion, wasn't recognized, and again, it's with huge consequences involved. So one of the things that's just recently come out, there was a test that was developed by the Banyan Group, and it received its initial FDA approval, and it's just hitting the market now, but it's a test that looks at the biochemical factors that are released, so these different proteins that enter the blood that they've identified that these are things that are released during a concussion. So to try and get the diagnosis, can cut down on the need for higher levels of studies such as CAT scans, MRI scans that typically are negative in a concussion. So with a negative MRI, you're basically looking for a bleed in the head and things like that. You can rule that out, but it doesn't rule out a concussion as well. And this can identify and give us a way of quantifying it and ruling it in, ruling it out. So I'm going to pass this on to Jeremy to give us a perspective from the athletic training side.
Thanks everybody for coming. I'm Jeremy. I'm a licensed athletic trainer. I'm actually the concussion coordinator for the hospital. So a lot of times we have like a hotline. It's basically this phone in my pocket. At any time somebody can call or message, or if they have a concussion, they don't know what to do. Let's say somebody goes into the ER and they give them at-home instructions. You have sustained a concussion. We're going to follow up with you with 24 hours. If nobody follows up with you, that phone number is on that sheet of paper as well. So we have a lot of resources, here at the hospital now to help people. ultimately get better. I think, with Dr. Orr talking about the signs and symptoms and severity and all that kind of stuff, I think that's one way to think about it. And the way I tell and explain my athletes is, what does our brain control? What does it control? Everything that we do, right? So you can only imagine what happens to your brain when it is damaged, right? When it's injured. We don't know. Every concussion that we deal with is different. Everybody's is different. It's not like an ankle sprain or an ACL tear that we see, your knee balloons up, right? We can't see what's going on inside of your brain, even with the MRI studies and the CT scans. So it's very important that we're always staying up to date with the current management processes and evaluation skills to basically recognize athletes that have sustained a concussion. Then the next phase is, how do we get these people and patients, athletes, to recover? And how do we get them ultimately to return to whatever it is that they want to do, whether it's work or sport? How many people ski? People ski. How many people ride bikes or like to take hikes? We're an active community. And I think that's really what we wanted to develop here, was that we are such an active community. There's so much that comes through our doorstep that we want to be able to provide a rehabilitation service or get you folks better and back to what you love to do in this mountain community. So I just wanted to kind of talk to everybody in regards to how I would basically go about recognizing a concussion or evaluating. So we have basically what is called a sideline concussion assessment tool. So it's called a SCAT tool. And so like what Dr. Orr was saying, those people that meet up in Berlin every 4 years, they developed this whole paper or evaluation tool. So it used to be SCAT 1. They met, a couple times, and then it was SCAT 3, and then we jumped to SCAT 5 because they didn't do a SCAT 4 because they just bypassed it for whatever reason. So up to date, this is by far the most utilized tool for sideline evaluation. It consists of multiple things that we do. They actually have two different ones because now children are getting more involved with sport at an earlier age, right? My daughter just turned 5 and they want to get her into, we're getting her into soccer and stuff like that. But, these balls can get kicked pretty high and all of a sudden, boom, reaction time isn't very good with a 5-year-old and, maybe she sustains a concussion. So they actually developed a child version where it's more susceptible to ask questions to a child versus an adult, okay? Because what venue, like if I ask my daughter what venue we're at today, she's like, venue? What's venue, right? And so they definitely change and reiterate those questions based on the SCAT version, the child version. So basically this is what it looks like. This is free for everybody. You can Google search right now on your phone, SCAT, and this is what would pop up. It would be a PDF file that gives everybody free information on how to recognize, what to do. All you have to do is follow instructions. Now, it's not something that I'm saying that you should go out and just you're the concussion person, right? This takes years of training. I mean, I've basically been able to memorize these things because I've done them so much. And we really try to have people that are qualified to evaluate people, but ultimately we are parents, we are uncles and grandparents and mothers and fathers and whatnot. So it's important to have this kind of information just in case you run into somebody that you can help. But it's definitely widely supported by, you can see FIFA, the Olympics, FEI, hockey. They all endorse this as their sideline assessment tool. So we have some pocket scats that we can give out, and that'll be for later. But what we really look at is red flags, right? Do we have double vision? Do we have tingliness, severe increasing headaches, seizure or convulsion? I think Dr. Orr was talking a little bit about a person that is on the sidelines. If we watch an NFL football game, somebody gets hit and they do this. We call that posturing. That's an automatic red flag. We know that person has sustained some kind of brain injury because it's just an involuntary response to a brain trauma. Okay? So observable signs. We look at people, are they lying motionless? Or they get up and they do something, they stagger, they stumble, right? These are all things that we look for. One, we look at basically mechanism of injury. The mechanism of injury is there some kind of blow or trauma to the head? or is it a whiplash or something? But a lot of times for football and whatnot, we'll see two people just go head to head with each other, and one person gets up and kind of staggers, and nobody else sees it, but everybody in the world was watching, and they all saw it, but everybody on the sidelines missed it, So they're trying to get better at, especially in the professional world, identifying these people with concussion. They have video replay. They can call down to the referee and say, hey, we think this person has a concussion, but still, there's not enough eyes on the field ever to be able to recognize these as well. So simple memory assessment. We can sit here and say, okay, what time do you think it is right now? What time? 7:30. So we give an approximation without even looking at the clock. So they give us an idea, say, oh, does this athlete know what time it is within the hour? Okay, so typical like football games would be Friday night under the lights, right? Most athletes know what time their game is. So we can ask an athlete, hey, what time do you think it is? And they're like, it's 4 o'clock in the afternoon, but it's dark out, right? We can recognize there's something wrong. Who scored in the last, who scored last, or what's the score? I even asked, what's your coach's name, right? And the coach is standing right there. And it could be a visiting team that I have no idea what the coach is. I say, what's your coach's name? And they say, it's Phil. And I look up and he's like, yeah, you got it. And so we can ask all these kind of questions. It's part of that retrograde, anterograde amnesia to identify. And those are just simple, basic questions that you can only imagine that people sustain a brain injury don't know, okay? So if they start to, when you're talking or looking at the athlete, this is when we start to, as evaluators, look at them. Or do they have are they responding to? Are they looking down at the ground? What's their posture like? Are they turning their head? Are they crying uncontrollably? These are all the things that we're looking for. Are they confused? Do they look oriented? Are they cussing at you, right? And so what are they doing? How are they acting? If you know the athlete, it's very helpful to understand this is not like Johnny, Other things is, do they have, pain with their neck movement? Do they have localized pain? Do they obey your commands? Hey, can we get up off the field? Can we get up off the field, And so if they're not doing that, that's all part of our assessment. And that's what we call as a Glasgow Coma Scale. We definitely look for the neck as far as we want to rule out any kind of serious neck injury as well. So we always ask if there's any pain in the neck, especially football or any kind of contact sport. We want to rule out some kind of cervical trauma as well. As you can see, there's a lot of going on here, right? Once we get through that initial evaluation, we get them off to the sidelines, we answered a couple questions, we want to start divulging into how they're feeling, okay? These symptoms that Dr. Orr talked about, you can see there's 22 very common symptoms. Number one symptom that comes with these injuries is typically a headache. And we have some kind of head pain or headache. A lot of times it could be dizziness. I've seen athletes throwing up. I've had them, just blank stare, stumbling, balance and steadiness. But we definitely go through the athlete's background. We look, what's the date and time of injury? What's your age? We ask, do you have any concussions in the past, right? We're getting a full history to be able to help this person, ultimately recover. So the evaluation part, I'm not going to get too deep, but I'm going to pick on a couple of you guys just to show you kind of what the process is like. So, Michael, I'm just going to pick on you since you're here. I'm going to have you remember these 5 words, okay? And then once I'm done repeating to you, I want you to repeat back to me, okay? Cat, pen, shoe, book, car.
Cat, pen, shoe, book, car.
And I would do that 3 times with the athlete. That's what we call immediate memory. I'm challenging your brain to see if you can obey that command and talk to me and remember those 5 words, right? Right off the bat. Then we would move to something like a concentration thing. What's your name, sir?
Jeff.
Jeff. Well, Jeff, so we would do like a number sequence, okay? So it would be, I would say, I'm going to give you 3 numbers. And when I'm done giving you those 3 numbers, I want you to repeat them back to me backwards, okay? So we're really trying to challenge your brain. So, if, for example, if I give you 197, you'd give me
971.
719. 791.
Yeah.
197. I'm concussed, I swear. So anyway, that's the idea, right? You give 197, 791, okay? You're challenging them. And if they get that, we would move on to a 4. So it'd be like 4, 2, 7, 1, right? And then you have to do that backwards. So moving along the process, if they get through that, they would go to a 5 number and then a 6 number sequence. We're challenging their brain cognitively, okay? Then we would go to a balance equilibrium score sheet. We're testing your balance. So Marie, why don't you come up here? You come on up and we're going to show them what the balance is. And so you can only, yes, because she was being very talkative. Just stand up right there for me. I'll give you a quick example. So the first of 3 balance tests that we do, typically with an athlete that is, right, like let's say they get a hit. Right off the bat, I'm going to check their balance because that's typically the number one thing that's going to go right off the bat. So I would have them stand there, maybe even on the field in front of everybody. Put your hands on your hips, hold it there, and then go ahead and close your eyes. And you can only imagine that everybody seems like they can do this, right? If your brain is injured, whoa, you know, people are stumbling all around, okay? And if they can get through that, then I would have them maybe stand there with their hands. You can sit down. But they would have them stand with their hands on their hips, and now close your eyes, right? And you can only see how easy it is, right, just to do that standing here, right?
It's true though.
Right, and so we would typically do a non-dominant foot when we test that. A lot of times what I'm looking for is just how unsteady is this athlete? A lot of times athletes should have some pretty good general proprioception, like I can stand here and do that, right? But it's difficult for just myself. And an athlete that's fatigued, and if their brain is hurt, they might be stumbling all over the place, okay? So we do one more, it's called the tandem stance. It's basically 1 foot behind the other. It's almost like walking. I always tell people it's almost like the DUI test, right? You know, we're like doing this, but it's you're just standing there and you're balancing the same kind of principles. We're just checking for proprioception and if there's any loss of balance or anything like that there. So then after all that, we would come back to a memory recall. So this test takes anywhere from 5 to 7 minutes. Do you remember those 5 words I gave you from the beginning?
Got a couple, look, car. Yeah, that's it.
Right, so that's the idea, right? We're challenging their brain for long-term memory, right? So that's why I do it. And now you say, okay, well, if they can't do that right now, like let's say they kind of mess up on the long-term memory, a lot of times I'll initially evaluate them, then I'll wait 15 minutes, and I'll do it again. Because I want to see if there's any change. Does their balance get better? Does it get worse? Does their memory get better? Does it get worse? If there's some kind of change, then there's probably something wrong with their brain, okay? If we're seeing something get better over time, and there was some, you know, they were very worse from before, that means they're starting to heal. But if they're getting worse over time, then obviously there's some more trauma to the scene, okay, that we have to recognize. So concussion information, you know, we definitely will give out those cards in the back, but it's just signs to watch for, you know, rest and rehabilitation. It gives all this on the scat, okay? It gives you the injury advice, who to go see, like seek a medical professional if you see, you know, increased dizziness or increased head ache, or maybe somebody starts throwing up uncontrollably, any what we call neurological deficit, like slurred speech, you know, like, whoa, there's something really going on. But as parents and family members, we kind of see people and understand that somebody's really deteriorating. Just get them to the hospital as quick as possible. Rest and rehabilitation, that SCAT-5 goes through a gradual return to sport. We have a graded exercise program. Typically, the kids that come back 7 to 14 days, we take them through a gradual exercise program to get them back. We are basically testing to make sure that their brain can, one, withstand increased blood flow to the brain, and then on top of it, can they withstand the bounding and jarring exercises that their brain needs to do to be an athlete. And we have basically a program that gets them to return to school, a gradual return to school process. Some doctors will recommend no school because their symptoms are so heightened. Maybe they need glasses or sunglasses because the lights are too bright for them, increased test times and stuff like that. So that's all on the SCAT. All this information, if you wanted to get, you could just go right through there. Lastly, it would be the child SCAT. There's a couple different, you know, words like I said, I feel dizzy or my neck hurts. They use a lot of, you know, first person language with the child SCAT. It basically that when you're talking to your child, say, okay, does your neck hurt, right? And they're like, oh yeah, my neck hurts. And is the world spinning? And instead of the symptom scale being a 0 to 6, 6 being the worst, it's just a 0 to 3, 3 being the worst. So they do have different stuff specified for children ages 5 to 12. More information, like I said, you can grab a pocket scat. We have brochures and booklets in the back that explains all this kind of stuff. And then I'll turn it over to Joe. Morgan.
All right. Hi, everybody. My name is Morgan Humble. I'm a physical therapist, and that's Joe Dianovich, the occupational therapist. I'll pass it off in about 2 slides to him. But rehabilitation approaches for concussion and mild traumatic brain injury. So you go to your PCP or your primary care provider or the speech therapist, and they said, okay, you need rehab for this concussion. We're going to go through what that looks like. Oh. Okay. Who's part of the therapy team? So speech therapy typically is going to be your first point of contact with the therapy team, and they may be seeing you. If you're admitted to the hospital, they may come see you in the hospital room, or you may get a referral for them for that first 2 weeks. You're typically seeing them as that first point of contact, and they have a screening tool to figure out if you need PT and or OT going forward. So then there's occupational therapy and physical therapy, and your symptoms will determine which members of the team you see. Timeline to therapy, just like I said, you may see speech therapy a little earlier than us, but PT and OT, if you get about that 2-week mark, that 10 to 14 day mark, and you aren't having much improvement or your symptoms are getting worse, then that's when you would get a referral from your primary care doctor, or that speech therapist would ask your primary care doctor to send in a referral to PT or OT. So a little bit about speech therapy, since Suzanne isn't here. She was part of the lecture last year. But like I said, they're typically the first point of contact, but that initial evaluation is going to be looking at some cognitive testing and education, any education that your PCP may have missed or you need some reinforcement on. That speech therapist is going to be there talking about sleep hygiene, social fatigue, learning fatigue, light and screen sensitivity, and then ultimately that return to learn and return to work, because we're not all just returning to sport, but rather we're going back to textbooks, or we're going back to sitting in front of a computer screen or budgeting, and that is a lot of mental task. So that speech therapist is going to be doing a lot of testing and then also education and giving you some modifications so that it can get you back to work and back to school as fast as possible. So some symptoms you may have that will indicate that you go to speech therapy include trouble concentrating, forgetfulness and memory issues, a longer time needed to complete simple tasks, headache or increased symptoms with cognitive tasks, inappropriate or impulsive behaviors, less ability to cope with stress, and more emotional or irritable, and then difficulty sleeping and word finding or conversing. So before you may have been able to talk to 5 people at one time, and now you have difficulty just talking to one person. So the speech therapist is going to go through some treatment activities for that, as well as giving you some modification advice. All right. Yeah.
All right, thanks, Morgan. So I'm Joe, I'm an occupational therapist. Very quickly, I just want to go over what occupational therapy is. Raise your hand if you know exactly what an occupational therapist does. Amy, because she's an occupational therapist. Cheater. So we are not physical therapists, but we work very closely with physical therapists and speech therapists. And our goal ultimately is to get our patients to return to the highest level of independence. And how we do that is we really focus on those meaningful activities or occupations. That's how we get the name for occupational therapy. So whether that's school, work, self-care, play, driving, hobbies, sport, whatever it is, we're going to look at it within that context. And we really try to take a holistic view to treat our patients. And that includes looking at the patterns of the activity, the demands, and the skills. So occupational therapists are trained in a broad range of ways to evaluate those things, whether it's visual perceptual things like we're going to talk about today, sensory issues, coordination, strength, biomechanics, all those things that contribute to being able to perform an activity. And then we use remediation techniques, adaptation, and modification, which are big parts of returning people back to those things that are meaningful for them. So we're going to do a little visual memory activity. So I want everyone to look at this. Look, look, look. Try to memorize as much as you can. And that's it. So how many people were in the photo? Just shout it out if you know.
3, 4.
3, 4.
I saw 3.
4.5. Morgan doesn't think babies are There were 5. There were 5. What was the cost for 2 pounds of bananas?
25 cents.
50 cents for 2 is 25 for 1, so good. What number did the boy have on his shirt? 5, yeah. So good. So there was a lot of information there. You had to use a lot of your visual skills and your perceptual skills to remember all of that. So good. Some of you did okay.
I failed.
And babies are people too, Mark. So OTs have a background in training and evaluating and treating visual, perceptual, and sensory impairments, whether they're congenital from birth or acquired. And as we're talking about today, concussion and other brain injuries are acquired injuries that can really affect someone's functional skills, whether it's the basic things that they have to do to take care of themselves, all the way up to high-level work activities. So vision and concussion. There's research out there that suggests that 82% of people who suffer from a concussion are going to have some sort of visual deficit. Now, it's not necessarily going to last. It might be an hour, it might be 2 hours or a day. But there are also people who are going to persist with these visual issues that are going to develop post-concussive syndrome, where they might need to come see rehab in order to address some of those things. As Dr. Orr talked about, concussions are diffuse injuries, so our brain is rattled around and it's not like getting a pinpoint issue in our brain. So everyone's brain is wired a little bit differently, and we see highly variable deficits from impact to impact. So 2 football players on one team might hit, and they might both get a concussion that affects their speech. And then the next day, 2 other players might hit the exact same way, and all of a sudden they've got visual issues. And we really need to have a team approach in order to evaluate, like Jeremy was talking about, in that moment, and then as we get those people out through the rehab process. So vision happens in the brain. It starts in our eyes, but really the workhorse of our visual system is the brain. And it's important to determine what is actually going on. And we can get some clues about where, if we know where the injury occurred, what kind of visual impacts we might have, but not necessarily. There's over 10 areas of the brainstem that are involved in visual processing, and up to 30% of our cerebral cortex, our outer part of our brain, that usually is the first part to hit the skull, is devoted specifically to visual processing. That's a lot of our brain powder just for our vision and our processing skills. Other sensory systems, so we have other sensory parts of our brain that can also be impacted because they're part of that cortex. So you can see, kind of the different colors or different parts of our system that may be affected, whether it's balance, our proprioception, as Jeremy was talking about, our sensation, we might have those different things that are affected as well. When we think specifically about vision and perception, I like this because it really shows you some of the skills that you need in order to function and do a lot of the things that we take for granted. So the first thing is just being able to control your eyes, to be able to move them in the places that you want, and then to be able to see the world as it should be normally. Sometimes after brain injury, we're missing part of our world. Our brain isn't perceiving it. And then acuity, so to be able to focus on things and see clearly. And then attention, so you have to have those things, and then you have to be able to attend. So if you're really sensitive to the bright lights in this room or the noise in the supermarket, you're not going to be able to attend to specific things, and you're not going to be able to function. Then comes some of the higher level skills that we're talking about: scanning, recognizing patterns, memory. We just tested some of your visual memory, your visual cognition, ability to then react to those visual things, and then adapt as you need to visual stimuli that come in. So here are a list of things that can happen after concussion or brain injury that are visual dysfunctions. So this is an example of a field deficit. So this person isn't seeing the whole left side of the world. You could be standing on their left and say, tell me when you see their finger, and they're not going to see it all the way until it comes right to in front of their nose. And it might not be that severe. It might be that they're just missing this 10% of this quadrant up here. Or double vision. So this isn't your eyes, Morgan. This is actually happening. It's flashing on. We did a practice, just like, is that me or is that you? So you can imagine when this goes double, how hard that would be for a child to read, or for a person to look at a computer, or to read a complex diagram if they're fixing a car. And some of these things listed, they're going to happen in maybe more severe instances, but they can be part of the problem that we're seeing visually. And we do want to work with optometry and ophthalmology if we're seeing some of these big problems, because these are issues that might need some things like special lenses or special adaptations that is more of kind of their focus. But if it's more of a mild thing, we can address some of those in therapy. Perceptual dysfunction. So here's another list of things now. Now, if our eyes are moving okay and they're teaming properly and do all those things, our brain still has to perceive all that information. So here's a list of things, whether it's speed, processing speed, adapting to dark and light and the sensitivities that we talked about, and then doing an analysis of the inputs that you have. Very rarely in mild brain injuries will people have problems with touch, smell, taste, but that can happen, so that's another thing to be aware of. And then more commonly, like visual disturbances, are proprioceptive, where your body is in space, and then balance, which Morgan will talk to you about next. So this cat has great visual perceptual skills. He is able to tell which one the mark is under, and that takes a lot of skill. So he has to be able to remember, he or she, maybe it's a female, she has to remember where it started, use her eyes to track, be able to recall the position, and then be able to follow through finally and say and acknowledge where it was. So that takes a lot of high-level processing that a lot of us take for granted until we have a problem with it. Here's another example of something that I might give to someone that I'm worried about their perceptual skills. So this says, how many times does the letter B appear? So you have to remember the directions, and you have to remember what a B looks like. You have to remember something called form constancy. So B's aren't always straight up and down. They might be turned, they might be upside down. And then you have to differentiate between a B or a P or a Q. And then you have to be able to scan. So you have to move your eyes back and forth and make sure you cover the whole page. And then you have to be able to separate where the lines cross. So you have to be able to do all that kind of complex processing in your brain in order to do something as simple as find the letter B's.
What was the answer?
Oh, yeah. Amy, how many are there?
I counted 7.
I'll get back to you. So red flags for visual impairment. So if you or someone else that you know has a concussion, if they're having trouble with their handwriting, if you're seeing really delayed hand-eye coordination, reading difficulties, or just trouble focusing in general, we may need to look at their visual system and see if that's a component to some of their problems. So as Morgan said, day 10 to 14, if patients are stable, if they're able to make it in the clinic, we want to start therapy. We want to at least do an initial evaluation and determine what they might need. So we have a bunch of different things we can look at. We can look at how the eyes move. We can look at vision without the motor component. We can look at their coordination. We can look at their visual fields. And then one I like to do is a handwriting assessment. You can tell a lot from someone's handwriting. It's a really complex skill to be able to write, and we can learn a lot from that. So treatments we might use, we're going to start with the basics. We're going to meet the patient where they're at, and then we're going to add to the challenge as they can tolerate. OT approaches are going to be task-based, meaningful, and backed by evidence. So the reason we want things to be task-based and meaningful is because they connect with other parts of things you already know. And we know those neurons are connected in your brain, so we can rely on those connections to help rewire and strengthen those areas of deficit. And then graded exercise and activity. Morgan will give you a great example of some of these things, but if someone's having trouble with certain stimuli or certain visual inputs, getting them on a program where they can increase their tolerance to those things. We rely heavily on the concept of neuroplasticity, so that's where the idea that this brain can heal and it can rewire and strengthen connections that have been damaged. And we like to say the synapses that fire together wire together. So that's why we incorporate all these things into our treatments in order to get the best possible outcomes. Another thing we're going to do is we're going to adapt, because brain injury is a slow healing process, and people want to get back to doing things. People want to be able to get out and enjoy time with their family, and we'll come up with adaptations to make their life easier so that they're not having so many symptoms while they're also recovering. And then conservation techniques. So using we each get a certain amount of time and energy every day, and using that to make it through the day and do what's important. Finally, home exercise programs. That's the key. If you come in for OT or PT or speech, you might see us for an hour a week. The real work is what you do at home, and if you actually follow through with our recommendations. So that's the people that are going to be successful are the people that follow through. And finally, if you're having some of these issues, check in often with either your primary care provider, your therapist, report changes, and then use your support system. Morgan will mention this too, but brain injury can be a huge impact on someone's life, and you need to rely on those social supports in order to get through some of these challenging issues that you might be facing. All right, Morgan.
All right. Okay, so now this is my bread and butter, not speech therapy. So physical therapy, you get a referral for physical therapy and you come in for that initial evaluation. What is that going to look like? Other way. So first things first, we're going to listen. We're going to listen to your symptoms, how they have changed over time, and then also what those symptoms are impacting. You used to be able to go out and run 5 miles, and now you can't even walk to the mailbox without your heart rate going through the roof and having to lay down for a couple of hours to recover. Or you can't go shopping in the grocery store because it's too stimulating, or there's too many people walking around and you just get a splitting headache. So we're going to listen to you, and then that's going to help us form our treatment program going forward. And then secondly, we're going to collect some objective data, and we're going to know what to test based on what symptoms you tell us you're having. So if you're having these exercise-induced symptoms, we're going to get you on the Buffalo treadmill test or the cycle ergometer or a 6-minute walk test, and we're going to track your heart rate and your blood pressure and your symptoms and your rate of perceived exertion, or how hard you feel you're working. And then that way we have a baseline score, so then we can develop this treatment program, progress you as your brain is healing, and then we can take that test again and see how you've improved, or if there's minimal improvement, maybe that's when we need to switch things up or get other players involved. So that's an important component of that initial therapy evaluation. And then, like I said, we're gonna do some treatment and develop that home exercise program. That's really what I want to focus on today, are some of those treatment programs and what we may see going forward. And then follow-up, that would be that retesting or communication with the athletic trainers or strength and conditioning coaches or sport coaches or teachers for that graduated return to sport and learn strategies, and being able to have that communication so then we're getting the best outcomes possible for our patients. So some symptoms you may be having that would indicate physical therapy would be exercise-induced symptoms of dizziness or a vertigo sensation, or the room spinning. Difficulty with static or dynamic balance, so you're standing at the counter trying to make dinner and you feel like you're going to fall over, and that's not exactly how it was before your brain injury, so let's figure out how to address that. And then lastly, neck pain. If you got a concussion and you whipped your head around and you injured your brain, then most likely you may have some neck pain, and we're going to address that. Neck pain can impact your sleep, and sleep is a huge component of the brain and your body healing. So if we can get that neck pain under control, then we can improve your sleep, hopefully, and then improve healing in the long term. So first I want to talk about outdated recommendations, so darkroom therapy. When I was in high school, I got a concussion and my mom put me in a dark room with no screens, no conversations, no sounds whatsoever for about 2 weeks until all of my symptoms resolved. And then as soon as I walked out of that room and the light hit me, my symptoms came back. So this is a very outdated recommendation. That doesn't mean that you're running out and getting back into whatever you were doing or you're going to the disco. We're gonna watch your symptoms and we're gonna have some low stimulation environments and we're gonna help facilitate that brain healing. We're not just gonna stick you in a no stimulation environment because we don't even know if your we can't even tell if you're having any symptoms to any stimulation because there is no stimulation. So that's an outdated recommendation. And it's also, Dr. Orr talked a little bit about this, but your blood flow in your brain has been shown to be decreased up to a month after an injury, with or without persistent symptoms. And the recent research has shown that one effective solution, exercise. So that's a lot of that objective data we're going to be gathering with the Buffalo treadmill test and other aerobic testing, is that we're going to build a program to get you back to exercising and increasing that blood flow in your brain to help with that healing. But it's all about finding the balance. This is kind of like a broken record, but everybody is different. Your physiological processes, how your brain is wired, everybody is going to present differently, and it's all about the ability to listen to your brain. Your brain is going to tell you when you've done too much, or your brain is going to let you know, I'm feeling pretty good, you could probably do a little more. And rehab helps you kind of tune into that and find those activities that we can focus on. And then also the amount of stress and social support in your life. The higher stress environment you have, the harder people have recovering from brain injury, and it kind of snowballs. But the larger support system you have, the better the outcomes. And it's all about finding that balance. How are we going to do that? We're going to go by the number one principle of treatment. That's going to be symptom-driven graded exposure, and the key words there are symptom-driven. So we are listening to your body, and the way we're doing that is you wake up in the morning and say, I have a slight headache. I'm about a 2 out of 10 right now with my symptoms. And then in therapy, we've identified what activities set those symptoms through the roof, and we're going to go do those activities. And we're going to go into that busy grocery store, or we're going to sit on the sidewalk and watch the shadows dance on the white fence, on your neighbor's white fence. We're going to let those symptoms come up about 4 points on that 0 to 10 scale, that beloved 0 to 10 scale. And once they raise up, we're going to remove ourselves from that situation and let your brain recover and perform some grounding activities, deep breathing, a low stimulation environment, some meditation. And we're going to have you recover back to that baseline level that you took before you went into that activity. And then we're going to have you repeat it. So that's a large component of therapy throughout all of our exercise, our vestibular ocular exercises, our balance exercises. It's driven by those symptoms. I already talked about this, but exercise-induced symptoms, we're really going to develop that exercise program because it is important for that blood flow. So that's one thing physical therapy will be helping you with is figuring out how much exercise you can do initially and then progressing that in a graded way so that we're not setting off your symptoms where you're down and out for a couple of days, but we're also challenging you. And then dizziness, vertigo, and balance. So you had this traumatic injury that gave you a concussion, but there are also other components that work together for your balance, and these components could have been affected in that same injury that gave you a concussion. So there are 3 components to balance: vision, which Joe talked about. Then there's also the vestibular system, and then sensation and proprioception. So the vestibular system, it's like a little internal gyroscope within each ear, and there are canals in there where it's filled with fluid, And when you move your head in space, that fluid moves and sends a signal to your brain telling your brain where your head is in space. So I can close my eyes and tilt my head to the side, and I still know my head is tilted to the side because that vestibular system told my brain that my head was tilted. And same with proprioception. So these are little, you've heard that word thrown around, these are joint receptors within all of your muscles and joints, and the sensation in your feet and through your body that tells your brain where your body is in space. So I know my arm's up here, or I want to touch my nose. I know where my nose is and where I need to put my finger, because there's that communication happening between the vestibular system, the proprioceptive system, and the visual system. And then your brain is there to integrate all of that. So you have your brain trying to integrate all of these things when it's injured after a concussion, but then you also have this initial blow that gave you the concussion that may have impacted these other components. One thing that's common after a concussion is BPPV, or benign paroxysmal positional vertigo. Basically, you have little otoconia in here, or calcium carbonate crystals that are within your inner ear. And with an impact where your head is jolted, sometimes those little crystals can come dislodged and end up in these semicircular canals, those fluid-filled canals I was talking about. And they're in there bouncing around off the walls and telling your brain that your head is moving when it's not. So say you roll over in bed and that fluid moves about in your canals, well, that little crystal is in there bouncing around saying that your head's going like this, when you really just moved your head and turned over in bed. And so your brain is trying to process all of this and getting these different signals, and that's gonna make you dizzy and most likely sick and nauseated. What can physical therapy do? We go through a couple of maneuvers depending on where that crystal is to get that crystal out of the canal. So this is an Epley maneuver, example of an Epley maneuver. But hopefully we can take care of that on that initial evaluation. When we see you and we determine it's BPPV, that initial evaluation, we can do the maneuver and take care of that vertigo symptom. So that's one thing that we can do right away on that initial evaluation. And then vestibular ocular rehab, that reflex loop where your brain is listening to your vestibular system and also your eyes and your visual input. That loop can be damaged in a concussion, and that brain necessarily isn't processing that information from your eyes and your head saying that, oh, my head's moving, or I'm standing still but I'm on a boat and I'm still moving here. So we want to, if you think about it like a road with construction, we want to open that road again and make sure traffic is flowing freely through there. So we want to practice that, and that would, I don't know if anybody's ever been in vestibular rehab, but it's a lot of this, a lot of this, a lot of walking with head turns, with the ultimate goal of having you, having the ability of walking down the street and talking to your friend, or driving and looking over your shoulder, or scanning the traffic. I get a lot of concussions, patients with concussions who come in who walk like this and talk to me like this because they don't want to move their head too fast, or a loud noise goes off and they have a reaction where they go like this and then they need to sit down because they feel like they're going to throw up. So that's something we work on. And then finally, neck pain. So it takes a minimum of 70 Gs in the average adult to cause a concussion, and it takes as little as 4.5 Gs to cause whiplash. So if you have a concussion that also involved the jolting of your neck, you most likely have some neck pain, and we want to address that. Neck pain and injury to the neck can cause dizziness, headaches, limitation in return to normal activity. And that's all something that we are going to address with manual therapy. So massage, active range of motion, passive range of motion, modalities where indicated, joint proprioceptive training, and then ultimately strengthening and pain management. And hopefully we can get that under control, and that will, again, facilitate your return from your concussion. At the end of the day, we're all a team, and you as the patient, you're at the top of that team because you're the only one who knows what's going on with your brain. And that communication with the rest of the team is going to allow us to work together and develop a program that will help facilitate that brain healing, because it's a process. And your involvement with your home exercise program, and then your ability to listen to your brain when you've done too much or when you can do more, is going to help us as a team facilitate that healing. Or if we need to get other team members involved, like nutritionists, to get on board. And that's it. So I'd like to open the floor for questions. If you also have any other personal questions you want to ask me, feel free to track me down afterwards, or if you want any research articles I may have referenced, feel free to write down your email. Yeah.